Who's doing our controls?
You're starting in me. Should we like last?
Yeah.
Yeah.
So you go.
I go with it?
Does one person want to be in charge of this or not? Yeah? All right, so this is your forward button. Watch.
Okay.
This is your back button. You can look at the back. This is your live table. And let me get my clock out of time.
Okay.
Wait, what?
Okay.
Well, you gonna introduce ourselves first?
Yeah.
My name is Omar,
I'm Juliet.
My name is Jess.
I'm Samantha.
Nikki.
and then we're doing a respiratory system, and we're doing an intubation presentation.
Mr. Jones, a 73-year-old male with chronic COPD, arrives at the emergency department presenting with dizziness, fatigue, and shortness of breath for the last 4 days. He has a barreled chest and clubbed blue fingertips. CPAP was used in transit TED by paramedics, but it failed to slow his breath per minute and raise his O2 levels. His vitals upon admission were as follows: heart rate 105 beats per minute, blood pressure 92/60. His respirations were 36 per minute, and his O2 levels are at 83%. The patient was a lifelong smoker diagnosed with COPD 5 years ago. He had been admitted to the hospital many times in the last year with respiratory distress. Providers used BiPAP but saw no improvements, and O2 levels and blood pressure continued dropping. Blood gas tests were run, and the patient had a PaCO2 level of 55 milliliters of mercury. Providers decided it was time to intubate. The purpose of intubating in this situation is to bypass the failing respiratory system, ensuring adequate ventilation to expel CO2 and prevent respiratory acidosis. Intubation with mechanical ventilation provides a machine to breathe for the patient, controlling oxygen and CO2 levels.
Okay, so a general overview, as Nikki kind of said, so what is intubation? It's a medical procedure where a breathing tube is inserted primarily through the mouth or nose down into the trachea to maintain an open airway, and the tube may be attached to a machine that helps deliver oxygen into the lungs, which is known as mechanical ventilation. And when is this procedure used? It's commonly used to keep the airway open to administer oxygen, anesthesia, or medicine. It can also be used when there's trauma to like the abdomen, chest, or neck. For respiratory failure, blockage during like aspiration, or sudden loss of consciousness. And how long does this procedure take? In emergencies, it can be completed in under a minute.
So, ventilation or endotracheal intubation primarily occurs in specific circumstances, that being in an emergency or controlled. So here we can categorize examples of what would be a controlled setting and a non-controlled setting. Primarily, intubation occurs in non-controlled settings, for example, emergencies, and can occur primarily in ambulances, where we see paramedics and EMTs complete this procedure in specific to 1 minute, because they are efficient in this specific process. And also in a civilian location, in the case that it is a very extensive emergency. So this process can be done, for example, in the home of the individual that requires this process, or a local setting. And in a controlled setting, we would have our personnel, our equipment, and all that would be planned, so it would be a much calm environment in comparison to emergencies, and in which it would be intensive care admissions and operating room. And who performs endotracheal intubation? Professionals specific to the healthcare system, primarily anesthesiologists, physicians, nurse anesthesiasts, emergency medical technicians, and paramedics are the ones that are primarily designed for this specific process, but also as advanced practitioner registered nurses. But registered nurses can vary. This varies on state regulations and healthcare systems. So upon completion of a program, you can be qualified and certified to complete endotracheal intubation.
So the procedure of endotracheal intubation, we do it step by step. So first we insert the IV and administer the anesthesia so they don't feel anything while intubation, because it could be really hurting. And step 2 is we put extra oxygen, because they may need more oxygen than it needs to prior to intubation. And then the step 3 is start the intubation where the doctor tilts the patient's head and then puts into called laryngoscope, which is like, it's like a camera that you can see the pharynx or the throat like that. And then step 4, we put the laryngoscope and we should see the epiglottis, and then we can lift it up using the tool to open up the vestibular folds so we can see the trachea. And then step 5 is when the endotracheal tube goes into the windpipe so the patient can breathe through it. We blow it up. We blow up a small inflatable cuff on the end to make sure that the tube is in place and it's in on the right, so it doesn't move. And then step 6 is we secure the tape, or we secure the tube by putting a tape around the mouth, and so that way it doesn't move. And then step 7 is we double check it if we did it right by either checking the breathing sounds and watching the oxygen numbers or x-ray.
So it can depend person to person how the recovery looks and how you feel after, but generally you will experience like hoarseness or sore throat because the tube is irritating your throat, and also a dry mouth because you're not breathing regularly, so you're bypassing the normal humidification and warming of the air, and it also reduces the saliva flow. And also fatigue because your body has already been under a lot of stress and probably low O2 levels for a couple days. Pertaining to Mr. Jones, like particularly, he might need a BiPAP because of his COPD history. It might help support breathing to prevent reintubation. Also, he'll need pulmonary rehabilitation and physical exercise to regain that strength and endurance with his lungs and his body, and also monitoring his oxygen saturation, so because his O2 levels can drop easily, so monitoring will help prevent reintubation. And also some considerations for the recovery time is age and overall health. Since he had COPD and he's kind of old, it might take him a little longer to recover, and also depending on the amount of time he was intubated for.
These are our sources.
Sources that we had.
What's a BiPAP?
It's like kind of like do you know what a CPAP is? It's
the
like
breathing
when you have
machine?
sleep, yeah, like when you have
Sleep
like,
apnea, yes, okay.
But a BiPAP, it has two forces of air. So when you're inhaling, it's like stronger, and when you're exhaling, it's lower. It's like a CPAP is constant air, I believe.
Okay.
Yeah, I believe.
Any other questions? I have a question. So on the early slides, it said it was you intubate through the nose?
Yes, nose or mouth.
Yeah. I think in a situation like your case study, it was probably a mouth for sure. Because
Yeah.
you gotta get air in really fast.
No, yeah. It just depends on the circumstances.
Yeah,
But
so
specific to-
intubation through the nose would be really minimal amount of airflow because you got a narrow passageway to put a small tube through.
Yeah.
And I was going to ask what BiPAP stood for too.
BiPAP or bypass?
By PAP.
PAP, okay, I thought you were saying bypass.
Any other questions? I'm going to bring in an intubation tube. I'll get one from the vet tech program so you can see what it looks like. The key to this intubation tube is two. There are two things to mention about it. I've done a lot of intubation in animals. So one is that the end of the tube has a little V-shaped end. So you actually use that V shape to bring the tube down through the epiglottis. You can literally like use it to part the ways. And two, it has a little inflatable cuff around the bottom of it that you use to inflate that cuff, and it holds the tube in place. The challenge with the inflated end of the tube is that you don't overinflate it, because if you overinflate it, then you're putting pressure on the end and the epithelium of your trachea. And what do you do when you put too much pressure on a delicate tissue? You kill cells, yes, so then you would have issues with that. So those are all considerations for intubation. So all of you are going to experience somewhere along the line, unless you were a dental hygienist.
How
And I
far
can
down
see
in the
it.
bronchi does it go?
Oh, you don't go past the bifurcation.
Just past, oh, you don't go past.
Oh,
No.
gosh, no.
No, yeah,
No,
yeah,
the
right,
point is
right, it
you wanna
wouldn't go
get
down
air to
there.
both lungs.
But so
Yeah.
just that,
So you're gonna measure, they're actually gonna measure the tube. They're gonna put the tube on the outside of the person and measure from the mouth down to like the sternum.
Mhm.
And you don't wanna go beyond the end of the sternum because that's about.
that's
where
about
the
how far it
intubation
goes
occurs.
down here.
So you wanna measure the tube
A long way to go
lengthwise,
to.
and then, of course, if you're doing a lot of intubation, you would have a sense about what size tube you're gonna use. Obviously, in medicine, veterinary medicine, human medicine, you have babies, you have children, you have young adults, you have, so you have different size tubes to go for all of those situations. And then the last thing is that you can have an emergency situation with intubation. Maybe your larynx is crushed. Maybe it's a car accident and the larynx is crushed and you got a cut through your cryotracheal ligament to get that tube in. And you could be not even an intubation tube, but a big pen has been used in the past.
Yeah.
Right, you take the plastic tube, take the pen part out, shove that through the hole. Exactly right. So good job.